Tori, can I ask you to unmute and come on video as well? And I want to just do some rapid fire questions from the chat. So I think the first question I would like to address here is, in the case that was just discussed, the platelets were 46,000. What is the evidence behind the use of enoxaparin in patients that have low platelets and that come in as acutely COVID positive?
It's a great question, and thanks to my colleagues for the great presentation, and thanks for asking us to be a part of this, and certainly happy to help. I think it's a challenging question, and there's not a lot of great data, certainly in the pregnant population, about what we do with that, or even in the critical care population, to say if a patient is thrombocytopenic, is that going to provide enough intrinsic decreased risk for coagulation and coagulopathies versus will further anticoagulation be beneficial for those patients? So I don't know that we have a great answer in any population for that question. And I think in COVID patients, whether pregnant or not, I would triage that therapy based on some of their other labs and some of their other coagulation parameters to determine what their risk may be. And that may be more challenging, with pregnancy, obviously knowing we're going to have a bleeding event at the time of delivery, and that may be an unpredictable event as well.
Dr. Jain, can I ask you another question, which is around the use of steroids? Now, in our previous sessions, we discussed the inappropriate use of steroids causing consequences such as mucormycosis. What is the current guidelines on the use of steroids in patients with mild COVID and mild hypoxia that are pregnant? And are there any negative consequences to use of steroids in these patients?
According to the recovery trial and all, they have really not advocated steroids for mild disease. So it's mainly for moderate disease that dexamethasone has been advised in the dose of 6 milligram, 0.1 to 0.2 milligram per kg. Or you can give hydrocortisone, or you can switch over to methylprednisolone, which can be given orally, and it is more specific to the lungs, and it doesn't really cross the placental blood barrier. It doesn't affect the baby also. So I think for mild disease, steroids is a big question mark. If someone can add to it, I would be very happy. Yeah.
Dr. Halscott. So for those of you I didn't get to properly introduce Dr. Halscott, he's dual board certified in OBGYN and pulmonary critical care, and he has written some of the national guidance documents on the management of COVID-19 and pregnancy. So what are the current guidelines on use of steroids in patients with hypoxia who are COVID positive and pregnant?
Yeah, absolutely. And I think it's a very important question. And I concur with my colleagues, for patients who are not requiring supplemental oxygen, there doesn't seem to be a benefit to steroids. But using that as a delineator, who is requiring oxygen, who is requiring hospitalization, those patients do seem to benefit. And we treat them similarly to the non-pregnant population. There's always this kind of consternation in obstetrics of, should we continue the dexamethasone? Is there a concern for causing fetal growth issues? In some of our older data, when we used to give that for fetal lung maturity very consistently, as my colleagues know, there was a concern for some growth issues for the fetus. Some of the other data hasn't borne that out as reliably, and that's with recurrent courses for longer periods of time than a 10-day course, consistent with how recovery trial and the other trials utilize it. So my personal practice is to utilize dexamethasone in the recovery trial dosing for 10 days. Some of my other colleagues around the country will do dexamethasone for a few days at the fetal lung maturity dosing that will typically, so 4 doses in the first 48 hours, first 24 hours, and then transition to a daily dose, or transition to methylprednisone or something that they have less of a concern for fetal growth issues. I think both those approaches are reasonable. It's just, I think that should be driven by local availability if there's any shortages of either of those medications. But as long as staying within the trial guidelines for treatment, I would treat pregnant and non-pregnant patients very similarly if they require oxygen.
I would like
Thank you so much.
Here, Bhakti, whenever we talk about the steroids nowadays, the recommendation is that it should not increase more than 6 days overall. There was a time when we were giving, 14 days of steroids. The women would be discharged on OD dose and then so BD and then OD and things like that. But now clear cut recommendation is do not give steroids more than 6 days. 2 days you can give IV and then you can put them on methylprednisolone on OD for 6 days. Because with the, influx of this mucormycosis, everything, the whole guidelines have changed, whether it is Indian guideline or the guideline all over the world. And the recovery trial has been really, really wonderful for taking this up.
One of the questions that came up early on that you asked the audience was, when the patient first comes to your labor and delivery with moderate COVID, what are the initial investigations that you should do? And so Dr. Burma, can I ask, would you be doing a routine CRP and D-dimer in all of these pregnant patients? Or like some of the people in the chat suggested, would you just do a CBC, platelets, and CRP?
Yes.
What is the standard at your institution and why?
So the guidelines we have from ICMR and globally also the recommendations are that when it is a mild disease, asymptomatic, a simple test confirming that she is COVID positive and then doing simple CBC, looking for the platelet, maximum doing CRP, and then accordingly, ensuring the 2 ways of treatment. So in India, what I would like to tell you is that the government has created 3 scenarios. The first one is COVID care center, where mild disease people who cannot manage themselves at home they can't come there, stay, and once they are negative, they are sent back home. There's second dedicated COVID care centers, which are district hospitals where moderate disease, which needs oxygenation and all, they are treated. And then there are COVID care hospitals, dedicated COVID hospitals, where, the severe cases are, they come and they are treated. And these are the places where, you have all ventilation and everything, all the facilities available to save them, all critical care is given to them. So that's the scenario in India. These cases actually do not need any investigations, especially, when you talk about interleukin-6, serum ferritin, this and that, they don't need those. Many of them without any treatment, without any unnecessarily giving them, there was a time when people were taking hydroxychloroquine as a prophylaxis, ivermectin as a prophylaxis, all that era has gone. There are several evidences stating that those drugs are not of any use at this moment. So mild disease is to be managed very easily with antitussives, paracetamol, and very minimal investigations, but they must know what are the warning signs. So those warning signs are extremely important. If they have any kind of breathlessness, if they are doing pulse oximetry and they see that the oxygenation is going down, they do not feel well, those are the cases when they have to come to the hospital and have the checkup, and then we can go for several investigations. So mild disease, they can stay at home if they can manage themselves, because the major problem of home quarantine is that people do not follow the instructions. They come out, they eat in the same place, they are together, standing with a little distance. That is not really home quarantine. When you say home quarantine, it is home quarantine, where you have to be separated, whichever way you want. You should not meet people. So if you can't manage that, we have created, the government has created for them COVID care centers.
Thank you so much. I have 2 last questions and I'm going to hand over to Dr. Hal Scott. First one is a very hard question. I think many of the individuals on this call are not obstetricians by training, but pregnant women with moderate COVID will present anywhere when they're in labor, and labor is a very unpredictable state. So for people like myself who work in the emergency department, if I have a patient who comes in unexpected with moderate hypoxia and COVID positivity and is in active labor, what are the practice considerations that need to be at the forefront of my mind when managing this patient? And I will pass that over to Dr. Jane and then Dr. Halscott.
Okay, so the practice, like in our places, like suppose she is in the case of moderate with this thing, we let her allow, and she's in labor. So we really don't try to shift her much, and with all the support and all, if she can deliver on her like bed itself, in whatever position, like if lateral position is comfortable for her, maybe we can give that. And if need requires, I mean, we can also, you know, without much like, because we had our anesthesia pediatrician team there itself, and the labor room and the OT were very close to the place where we were keeping our patients, so we could immediately take her for a C-section also, so that was not a problem. So position, I mean, whatever dorsal position she is or in a lateral position, on her own bed, if she can deliver, it's well and good. We need not shift her to a delivery table if it's not required.
So I think my question is around the patient who has moderate hypoxia and likely hemodynamic instability. Should we be doing an early C-section? Or should you be transferring early? Dr. Halscott, any advice for when this patient shows up in my emergency department, if I'm not at Johns Hopkins and I'm in a district health facility, what are my considerations?
Certainly, and you're right. It's a challenging issue and a resource intense issue potentially. You know, I concur with my colleagues. You know, stabilizing the mom is the mainstay of obstetrical care. The physiology of the fetus is designed so that as long as the mom's doing okay, the fetus should be doing okay and getting the oxygen and performing the ventilation it needs at the local level through the placenta. So focusing our efforts to optimize mom's oxygenation, and in pregnancy, we tend to shoot for a little bit higher pulse oximetry of 95% or greater. So if we're able to achieve that, then we should be able to achieve good perfusion for the fetus as well as for the mother, as well as keeping the blood pressure elevated, mean arterial pressure greater than 65. Our general critical care data, we utilize that in pregnancy as well. So your typical, vasopressors, if they're available, would be needed a fluid bolus, to get the blood pressure in a good range, so that that patient can get to the obstetric ward or can get transferred to a hospital with obstetric capabilities to balance those. I think the delivery mode, vaginal versus cesarean, depends a bit on the situation at the time. The amount of dilation, if she's ready to deliver at the moment she presents. Or if there's another indication, fetal presentation or something else to do C-section. But I wouldn't say that COVID or even COVID severity in general should be a direction for one mode of delivery versus another. And that's what we've been doing. We've been having the mode of delivery determined by the typical obstetrical indications as much as feasible.
Great. So Dr. Halscott, I'm going to ask you to share your screen. And Dr. Verma, I know you're going to add to this, but also I have two very important questions for you. One is there any contraindication for vaccination in COVID-19 in pregnant women, and any contraindications to breastfeeding in pregnant women? I know the answers, but I want to confirm these answers from the expert. And I'll hand over to you. And Tori, please start sharing your screen.
No, so very clear guidelines are there that there is absolutely no contraindication for vaccination, even in the first trimester, which is the worry of most of the obstetrician. It's very clear that we can take vaccination as per the doses which are there. There are questions that should we take Covishield, should we take whatever vaccine is available at your place, you please take that, and the second dose, whichever is scheduled. Breastfeeding also, there is no contraindication of breastfeeding at all. It's just that, the women is guided that she should keep a face shield, she should keep a mask, and ensure that she keeps a little bit of distance from the face, but there are no contraindication for the breastfeeding now.
On that note, and it was an important question because people still have doubts, but there's absolutely no contraindication to vaccination or breastfeeding. And I'm really excited about the breastfeeding studies that have been done. And many mothers early on in the pandemic, myself included, contributed to those, and have shown that there has been transfer of antibodies into breast milk, which makes us all feel good. So I want to summarize. We've had a lot of very interesting talking points here, but we want to put this in a systematic, ordered way for you to learn. So I'm going to hand over to Dr. Halscott, who's going to run through the evidence behind COVID-19 management in pregnancy, and then we'll answer any questions at the end of the presentation. So